Good evening, everyone. A warm welcome to all of you. I am Arpita representing the IGCP group, and it's my great pleasure to host today's special webinar on the eve of World Heart Day. Our theme this evening is Building Healthy Hearts for Life. Our theme this evening is Building Healthy Hearts for Life, a multi-generational panel on cardiology. Heart health is not just a medical concern, but a lifelong commitment that spans across generations, right from childhood to old age. Today's discussion brings together eminent cardiologists and healthcare leaders who will share their insights on prevention, early detection, management, and lifestyle choices that can help us protect the heart at every single stage of life. This panel is designed to provide practical knowledge for clinicians and the community alike, focusing on how we can collectively build healthier hearts and healthier lives. Without doing further ado, I would like to introduce our moderator for today's session, Professor Dr. I.B. Vijayalakshmi ma'am. It's an honor for me to welcome ma'am and to introduce her to everyone. Ma'am is a Professor Emeritus, Professor HOD of Pediatric Cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research. She is a skilled interventionalist, pioneer in pediatric cardiology, pioneer in Amplitzer device closure. She has delivered 31 prestigious orations. She is past president, Indian Academy of Echocardiography, a brilliant academic career, and has secured 41 gold medals. He has proposed the echo criteria for the early and precise diagnosis of carditis in acute rheumatic fever and national policy for congenital heart disease. Best Presentation Award at PICS at Chicago and in Boston, first prize for outstanding scientific presentation at World Congress of Echocardiography. She has received Lifetime Achievement Award from American College of Cardiology of Indian origin in Atlanta in 2023. Ma'am has authored Step by Step to Echo in Congenital Heart Disease, for which foreword is written by Dr. Naveen Sinanda and edited three textbooks Acute Rheumatic Fever and Rheumatic Heart Disease, a comprehensive approach to congenital heart disease, for which the book review has been written by Dr. Crystal Moningsen of Mayo Clinic and published in European Heart Journal. Dr. Mullins has written forward to Cardiac Catheterization and Imaging from Pediatric to Geriatric, edited by her. Ma'am has received 70 prestigious awards, including Rajya Sabha Award, Lifetime Achievement Award from Bharat Ratna Abdul Kalam Ji, and former President Srimati Pratibha Patel Ma'am, four chief ministers, and won Best Paper seven times at national and international conferences. So, with that, I would now request ma'am to please start the session. Over to you, ma'am.
Thank you so much, Arpita. Good evening and wish you all a very happy Navratri. It's my pleasure to introduce my learned panel, and each one is very brilliant. The first I would like to present Professor Dr. Vijay Bang. Dr. Bang is a national and international award winning senior cardiologist with 30 years' experience in angiography, angioplasty, and pacemakers. He has performed more than 10,000 angioplasties and many in complex scenario. He has won many awards due to his work in angioplasty. He is truly regarded as one of the best cardiologists in Mumbai. Course director of India Acts Conference at national level for complex angioplasties, valve therapies, pacemaker implantation, acute heart attack, emergency angioplasties with the renowned international faculty from USA and Europe. The event organized under the auspices of Cardiac Vascular Academic and Research Foundation, Mumbai, of which Dr. Vijay is the president. Dr. Vijay Bang is the professor for PG training cardiology and also DNB students. And my second panelist is Professor Dr. Vivek Chaturvedi. Vivek is a highly experienced, acclaimed cardiologist having over 15 years of experience. He has served as professor of cardiology and in charge of arrhythmia and electrophysiology service at prestigious GB Pant Hospital. He is a national authority in the field of electrophysiology, radiofrequency attestation, and complex device implantations. He has over 50 publications, and Dr. Chaturvedi has performed more than 2,500 cardiac ablations, several of them for complex arrhythmias. His proficiency further extends to coronary and peripheral angioplasties as well as the mitral valvoplasties in rheumatic heart disease. And he happens to be from the same hospital where Madam Aurora used to do the valvoplasties for mitral stenosis. And at one time, she was the one with the highest valvoplasties on earth. His commitment to advancing cardiology is further underscored by accolades such as the A.V. Gandhi Award for Excellence in Cardiology for the Best National Thesis Research Paper in 2008. And now we have none other than Dr. B. Hygrev Rao. He is a senior consultant cardiologist and electrophysiologist, KIMS Hospital, Secunderabad, India. Currently, he is the director of Division of Pacing and Electrophysiology with large group of hospitals. His awards and important invited lectures are DP Basu Award by CSI, National CSI Annual Meeting in 2009 and 2012, Kerala Annual Meeting in 2006 and 2013, and the list goes on. He is an editor of Electrophysiology section, Indian Heart Journal, and section editor for Indian Pacing and Electrophysiology Journal. Dr. Rao participated in several national and international conferences as an invited speaker. He has published more than 50 peer reviewed papers. So, friends, you can see that we have the galaxy of learned people. So, now I'll give an intro to the today's discussion, the Odyssey of Healthy Heart from the Womb to Tomb. Now, this year's slogan for the World Heart Day is Use Heart for Action. Don't miss a beat. Love your heart, it's your life. And these are very, very important ones. But everybody thinks William Harvey is the father of cardiology. No, even before the Vedas, the Narayan Sukta described the heart so beautifully. It said that it is a center for all the blood vessels and oscillates in the chest of the left side. First, it takes nourishment to itself and then it supplies to the parts of the body. We know that coronaries are the first branches. In the center, Agni is installed in a subtle form, and we know the mitochondria are the powerhouse of the energy. And this is the abode of universal Paramatma. So it maintains the temperature from head to toe. This subtle molecule installed in the heart itself is a Brahma, it's a Vishnu, and that is the Maheshwara. And it looks like a lotus bud which is downwards. And today, friends, in the whole world, if you look at it, the heart is the only one which is the perfect harmony. The harmony goes only when there is a structural defect. Otherwise, it is the perfect harmony is there. Unfortunately, today more and more children are being born with the defects because of the many factors. And here you can see that more than 20 lakhs children are born with the congenital heart disease. Out of that, almost 80% of them, they never even celebrate their first birthday. And all this is can be prevented provided the people understand what is the problem. The heart starts at the 6 weeks of pregnancy, that is in the fetus when it is 6 weeks. And at 6 weeks to the 12 weeks, if the mother takes care, and then it will be better. So here the maternal infections like rubella, now it is better because rubella vaccine is being given, pulmonary stenosis, VST, AST, and the intake of the drugs.
Yes.
In the past, the other things were taken, but today, antidepressants, then anti-epileptics, anti-asthmatics, these are the drugs which are causing the congenital heart disease. More than anything, the women are competing with the men, and alcohol abuse is the one which leads to the fetal alcoholic syndrome, and the 50% of the congenital heart diseases are because of the alcohol consumption. And apart from that, the other factors are there, and the maternal diseases. Today, the obesity has increased in the mother, and in fact, the cardiodiabetic syndrome starts in the fetus, and the diabetic mother with TGA and other conditions can be there. So, obesity is also a big problem, and that can lead to the problems. But today, we have folic acid, which should be started before becoming pregnant, so that the nuchal, that the spinal bifida, as well as the congenital heart diseases, can be prevented. So, fetal echocardiography has come in very handy. And you can see that optimal timing is between 18 to 22 weeks. And if they are complex congenitals, we can terminate. And then, if they are simple, we can tell them that what can be done. So, as in this picture, you can see that karyotyping can be done if the gene problems is there, and if the AV canal defect is seen in the fetal echo, we can describe with the pictures to the parents, and then say that even if we repair the heart disease, the
कदा
child will not be normal
आपल्याला
if
ते
they want to
हां
terminate.
ते
So
त्यांचं
today,
प्रॉब्लेम झालेला आहे.
intrauterine
या
interventions are possible. So this
ते
is how, even in Hyderabad, where Dr. Haigreve comes, he knows that this is being done in Hyderabad, and the intrauterine
that
interventions
will
are
be done.
possible.
It will be done.
But this is the hydros fetalis, pinpoint aortic stenosis on ventilator. It was just 14 hours baby, and I did the balloon angioplasty with the PTCA and literally saved. Otherwise, hydros fetalis is a certain death, and that can be prevented. So you can see that a pinpoint aortic stenosis is opened up, and the gradient also improved, and the ejection fraction improved from 30 to almost 60%. Friends, today preterm infants who underwent had PDA, they can be closed with the newer Amplatzer device, that is the Piccolo. And with this device, even as small as 600 to 680 grams can be treated. We can do the valvuloplasty in pulmonary stenosis. We can also implant the transcatheter valve replacement. And what is important is the AST device closure was introduced in 1998, and then today it has almost, surgery is not indicated at all, and we can close any of them provided the rims are adequate in the ostium secundum AST. In the past, the histopathology used to show the endothelium growth. Now 4D echo shows the endothelium growth on both the RA side and the LA side of the disc. And this is a 9-day-old neonate on ventilator, 2.2 kilo large PDA, and it was closed with the 3 by 4 ADO2 in the fourth French Cook shuttle sheet. And here, this patient had a complete heart block, and this patient was referred for the epicardial pacing later on. So today, not only the device closure and the surgery, we also have the hybrid surgery where a large device can be put with the small nick and the purse string suture done by the surgeon, and I put it with the catheter. So today, when our data is compared all over the world, you can see that marriages in India are made not in heaven but in families. But still, we have AST, VST, PS, PDA, all can be literally cured, and they can be having a normal life for their whole life, and the tetralogy can be repaired. And this is how, when you compare to the other, the complex congenitals are much less in our country. But unfortunately, if we don't treat them in time, like Madhubala, who had a large VST in Mumbai, and then she died of Eisenmenger's. So we do not want any child to die of that, because the echo is so precise. As small as 2 millimeter VST also can be detected. My professor used to tell medicine is magic, surgery is logic. But now I say surgery is logic, but intervention is magic. But interventions have to be done in time. This is the achondroplasia patient with full term pregnancy, and she was not fit for surgery or cesarean section. I did the balloon valvoplasty in the morning, and evening she underwent cesarean section. This is the lady who came with the pulmonary apoplexy with the almost 4 millimeter orifice, mitral orifice. We did the balloon dilatation, emergency, and next day she delivered. So today, even in dextrocardia, we can do, and we have a transesophageal echocardiography. We can make out whether there is thrombus in the left atrial appendage, and we can decide. And not only that, transcatheter mitral valve repair and are also there. But now coming to the crux, the acute MI is the one which is the prime killer in the prime of life. It strikes like a bolt in the blue. Now, even women are not away from that. Incidence is increasing. And it is so frightening that in the last 40 years, the heart attacks have increased 4 times. And it is so much so that it is almost like 4 jumbo jets crashing in one day. But people are not aware. Only when a celebrity dies, only a young person dies, only somebody dies in the gym, then papers and the media will talk about it. Otherwise, people are not aware how many are dying. And this is that time is the muscle. Within 1 hour, the treatment has to be given, otherwise, we lose. But today, most of the youngsters, they are have killing themselves by stress. And this stress, a beautiful Samskrita shloka is there. Chintayascha chitayascha bindu matram vishishyate. Chita dahati nirjivam, chinta dahati jivanam. Kintu vyathyasa adhika bhavati. That means there is a only one zero difference between chinta and chitta. But that difference is too much, because chinta burns the living person, whereas the chitta burns the dead person. So when coming to the stress, you know that the stress has a very bad effect on the body. The protein synthesis production is reduced, the poor digestion occurs, increased blood clotting occurs, increased blood pressure occurs, and higher cholesterol, fatty acids in the blood, faster breathing and the heart rate, and body releases more sugar. So stress induced diabetes, stress induced hypertension, both are there. And apart from that, hydrochloric acid is also increased. And so people cannot distinguish whether it is the gastritis or the retrosternal burning is due to the heart attack. So we have to change our attitude, and then the type A personalities are dying very, very early. And recently, in the last few months, we have lost even the most promising cardiologists and the cardiac surgeons also. And in this direction, we have to change our attitude and go to the age old method of stress management by the meditation. And this is very simple, relaxing. We have mantra meditation also. Today, we know that the negative emotions can lead to the stress. The anger, frustration, depression, everything can cause, and that increases the heart rate, blood pressure, perfusion demand mismatch occurs, and vasoconstriction occurs, especially when person gets angry. 400 times more catecholamines are released, and that leads to the coronary vasospasm and the myocardial ischemia. And hence, in this direction, the meditation helps. Mantra meditations also there. And there is a science behind positivity. People who maintain a positive outlook in difficult situations are more likely to emerge more robust and resilient. The brain neuroplasticity allows it to adapt and change. That is the reason we should have positivity. But today, another big problem is the obesity. You can see that truncal obesity or abdominal obesity, you can see that when you look at the spelling of abdomen, B and D, they look like this. And what is important is after corona, 30% obesity has increased among the men, women, as well as the children. And this has to be taken very seriously. On one hand, we have the physical exercise remains one of the best ways to lower the heart disease risk factor. And that is the reason people go to get the six pack. But there is a paradox. Many youngsters are dying suddenly while doing the gym. But in contrast, we have never heard of any death in the Akhada where they worship Hanuman and eat badam and halwa and drink milk, and then they become world champions. And this from childhood to the heart attack to the old age, the stroke, you can see that the carotid artery is blocked and all can be tackled. But the only problem is when it is due to the stress, the drugs and the treatment fail. And in this direction, in 2002, the Japanese, they did a study where a very young people coming with the heart attack symptoms, the coronaries were normal, but heart was bloated and it was dilated, ejection fraction was reduced, and the LV dilatation looked like a octopus trap, and that's how they called it as a Takotsubo cardiomyopathy or Takotsubo syndrome. And when they didn't have anything, they gave a Sri Maharshi Mahesh Yogi's transcendental meditation to these patients, and within 72 hours, 15%, 20% ejection fraction came back to the normal. And then the whole world realized the brain, heart, and the body axis, and the people started believing in the positive thinking and then meditation, which release the endorphins and the neuropeptides. And that is the reason it is very important all over the world to preserve the heart and their own life. The people have started doing the meditation. And evolution of human beings, if you look at it, it is really depressing. We are going in the wrong direction. So friends, to conclude, I would like to say that today all over the world, all the guidelines stress upon the lifestyle modification, whether it is for diabetes or hypertension or heart attack or cholesterol. And here, the preventing the smoking, spirit, that is alcohol, stress, sedentary habits, sleeplessness, and sitting for a long time. All this can be changed by the yoga and meditation with the Bhava Vikasa, Mano Vikasa, because whatever we do, streptokinase, PTCA, PCI, transplant assisted device, or the CABG, implanted cardioverter, defibrillator, whatever it is, we cannot save them unless they make their mind to save themselves. So the old roots of divine intervention, that is DI, supporting the new interventions with the AI are very, very important. So hence, Jaisa and Vaisa Man, Jaisa and Man Vaisa Tan. So friends, to conclude, I would like to quote a Japanese text which says 2600 BC, superior doctors prevent the disease, mediocre doctors treat the disease before evident, inferior doctors treat the full blown disease. And hence, we have to take a leave from the ancestors and we have to go back to our age-old method of living with a beautiful life and always smiling. And thank you very much for your kind and patient hearing. And now I would like to invite my esteemed panelists uh, for the discussion. Yeah. Dr. Bang is not there? Okay, we'll start with yes, Vivek Chaturvedi ji, namaskar. So,
Namaskar.
friends, we are going to have a wonderful discussion. We have 3 panelists, and each one is eminent. As you know, I have introduced them. So, I will start with Dr. Chaturvedi ji. So, recently, heart attacks are increasing young. What is the reason?
So, ma'am, the commonest reason for the increasing heart attack in the young is that more heart attacks are being recognized. Earlier, they
Okay.
were not so much recognized. Now, social
Okay.
media and webcams and everything, increased awareness is there. But more importantly, another big reason is that we are acquiring the risk factors for heart disease like smoking, diabetes, etc., at a younger age. And that is why once the risk factors for heart disease occur early, then you get more heart disease. Also, the rupture of the plaque, the atherosclerotic plaque, which is causing heart attacks and sudden death. Typically now there is a lot of fear in public's mind regarding gym goers and other things. So any kind of excessive and unexpected physical or mental stress can rupture or erode these plaques within the coronary arteries, and
Yeah.
that is a cause for MI or SCD in these people. And
Yes, sir.
there
You
are several
rightly told
factors for
about
this.
the gym, the gym goers, they have started taking the energy drink which contains 70 milligrams of caffeine, and they also take the formula which contains the corticosteroids. or the banned drugs. So that is also adding up. And after the
Yes.
corona, the youngsters have become very lazy. The activity has come down. Obesity is not there. The partying is there, and the drug abuse also has increased tremendously, and that is also
Yes.
adding up, sir. So
Yes.
thank you very much. And now we move on to the second question, Dr. Haigriv Rao. What is the difference between the heart attack and the cardiac arrest? Because whenever we go for the discussion to the TV channel, everybody confuses. So please elaborate that.
Thank you, madam. Uh, it is very commonly, misconceived between these two findings. Now, basically, heart has blood supply by means of coronary arteries. Now, due to various reasons and due to age, gradually fat begins to deposit in these arteries. And then one fine morning, suddenly the plaque ruptures and a clot is formed. And this clot completely cuts off the blood supply to one portion of the heart. This is called as heart attack. Now, a heart attack is generally manifested by chest pain, chest discomfort, and some of the patients, or most of the patients, do get time to reach the hospital and something can be done for them. Now, on the other hand, a cardiac arrest is an electrical disturbance of the heart. What actually happens is there is an electrical disturbance which leads to the lower chambers of the heart beating at a very fast heart rates like 250 or 300 and leads to instantaneous death. Now,
Oh,
most of the times, patients never reach hospital, and unless a CPR or a cardiopulmonary resuscitation is done by a trained person, they do not survive. And it is interesting to note that many heart attacks can lead to cardiac arrest. Now, cardiac arrest is less known. Most of the people are celebrities who die suddenly and reported in the newspapers. They're actually cardiac arrest, including our late president, Dr. Abdul Kalam. But what is reported by a lesser known journalist and the media is that they had a massive heart attack. It may be true, but most of the time it is not. Most of the time, instantaneous death is cardiac arrest, whereas chest pain and going to the hospital is heart attack.
so thank you very much, sir. Very beautifully explained. Now moving on to Professor Dr. Vijay. In fact, when a person comes with the heart attack, nowadays people are having multiple risk factors. And then, apart from the culprit artery, you see the diffuse disease in most of the vessels, multiple vessels. So how do you manage such cases, sir? Because you are expert in managing the difficult cases. Sir, unmute,
Sir, you're
sir.
mute.
Sir, please unmute. Sir, unmute, sir. Okay.
Now she has unmuted
Yes,
me.
sir. Yes, sir. Please.
Okay. So what I suggest is that in this difficult situation of patient having multivessel disease, and one has to identify the culprit artery, there's going to be a challenge, and it's a twofold challenge. It's in acute MI and NSTEMI and STEMI. Different challenges are there. If it is STEMI, then intravascular imaging OCT particularly helpful in defining. If there is non-obstructive disease, if there is no thrombus, then we have to use this intravascular imaging to define whether heart attack is there or not there. OCT having a higher resolution, it gives very good idea about erosion and rupture of the plaque. So if these two things are there, it clearly dictates that that artery is a culprit artery for the heart attack. Whereas in NSTEMI, we have to go to a different mode of diagnosis, which is delayed enhancement in CMR. So that is the only way we can detect the diagnosis. But the beauty of finding out this through the research, that delayed enhancement has a great role in NSTEMI to define the culprit artery.
Okay.
And in that, there is 60% of the time the delayed enhancement is detected and MI is there in NSTEMI and culprit artery is identified 60% of the time. And 13% of the time it's not MI, it is other diseases.
Okay.
Other than like, the Takotsubo,
Yeah. They have
amyloidosis,
the osteal lesion. Yeah.
amyloidosis. And these are the lesions which again can increase the tropi due to heart failure and so many other things. but it's not necrosis. It's just different kind of myocarditis. Tropi can be increased. So these are the things where two different modes. STEMI has intravascular imaging to detect culprit artery. If there is no thrombus and there is no slow flow in any artery, then it's very difficult to identify which artery is culprit. And non-obstructive lesion, then intravascular imaging is the ideal method to go for it.
Yes, sir. Thank you very much, sir. Dr. Chaturvedi, just now Dr. Rao told about the ventricular fibrillation and sudden cardiac arrest. But there are certain older people, they come with the pulmonary edema, breathlessness, and the palpitation, and we find that they have the atrial fibrillation. Sometimes they come with the stroke. And so, how do you manage this atrial fibrillation? What is it, and how to prevent and how to manage it?
Yes, so very rightly said, atrial fibrillation is the commonest arrhythmia in any population worldwide. And while we are all aware that it is the biggest reason for ischemic stroke, including in India, most of the people don't realize that it is equally a very big contributor to heart failure and hospitalization for cardiac problems. And this was shown in the Kerala AF registry that many of these patients get very, very sick after the time of diagnosis.
Yes.
So the easiest way to treat AF is prevention. And the biggest drivers of AF in India are rheumatic heart disease,
Yes.
obesity, alcohol, and sleep apnea.
Yes.
And also the traditional risk factors like diabetes and hypertension. So
Yes.
rheumatic heart disease is declining now, and the other
Yes.
things, they are all entirely preventable lifestyle related factors. And if we
Yes.
aggressively manage them, it should be possible. As far as the treatment is concerned, depending on their propensity for developing thromboembolic events by JADS score, we anticoagulate them for prevention of stroke. It is very effective in that. And rhythm management of AF is very important. Wherever we try drugs, if the drugs don't work, then very effective ways of ablation are there so that these
Yes.
people can live a normal life.
Okay. Thank you very much, sir. Very nicely explained. Dr. Rao, nowadays, despite the best treatment, many people, they are not availing the technology and the treatment, and they come in a heart failure. Once they are in the heart failure, they start begging, do something, doctor, somehow save me, give me a better quality of life. What do you do at that time? What is the role of pacing there and the automatic defibrillator? How do you manage these patients?
No, this is a very clinically relevant problem in the society because the heart failure prevalence and incidence is progressively increasing to large proportions. Now, basically, heart failure means that the pump or the cardiac pump is not pumping adequately to supply blood to all organs of the body. Patients with heart failure typically have two streams of clinical problems. One problem is they become increasingly breathless, they have edema. First, initially by walking, they get breathless, and finally, even on lying down in the middle of the
Yes.
night, they wake up with breathlessness.
Yes.
So this is one aspect. The second aspect is all patients with heart failure are prone to get cardiac arrest. They can die suddenly. So these are
Yes.
the two important streams of problems with the clinicians face.
Yes.
For the first problem, that is breathlessness. Now, for the last 20 years or so, pacing or pacemakers have been introduced, and they have contributed immensely to the management of these patients. Now, what they do is the pacemaker involves three different wires placed in three different chambers of the heart, and this is connected to a battery run pacemaker. And what it does is it helps the heart to pump better. And this technology is called as a cardiac resynchronization therapy, or the CRT.
Synchronization. Yes.
Now, but unfortunately, not all heart failure patients are candidates for CRT. It is
Yes.
very important for the clinician to be knowledgeable, to be able to recognize and recommend only to those patients who are likely to
identify the
respond to this
patient. Yes.
therapy.
Yes.
Correct. So typically this is done with an ECG, which have a left bundle branch block and with some echocardiographic parameters. Otherwise, if they are given to patients who are not likely to respond, it will be counterproductive. Not only it will not help, it may worsen. Now, coming to the second stream of problems, that is arrhythmias. The patients with heart failure or weak pumping of the heart are prone to sudden cardiac death because of dangerous ventricular arrhythmias. Now,
Yes.
the way to treat these patients to introduce another pacing-like device called implantable cardioverter defibrillator, or the ICD. Now,
Okay.
if you put this is also like a pacemaker. It is a lead which is placed in one of the chambers of the heart, and whenever cardiac arrest occurs, the ICD detects the cardiac arrest and gives a shock and saves the patient's life. And this
Wow.
is irrespective of the patient is awake, sleeping, walking, talking, or whether he's traveling, wherever he is, any
Okay.
part of the world, any small village, this will automatically take care of itself. So this
Okay.
has been proven to save life. So the
Yeah.
interesting part is this ICD can be combined with a CRT device and what is called as a CRT-D device, that is a CRT
Okay.
pacemaker with a defibrillator. And
Oh,
that is how it can help both the pumping and both. But needless to say, the final word is again the right identification of the patients and also in the right hands, because putting a device is not the end of the problem.
that would
They
be
should be electrophysiologists that should be involved
experience.
who are going to manage these patients after the putting the device. How to program this device, how to follow up this device. It is very important to know all these things.
What is the cost of it? But of course, the cost doesn't matter because the cost of life cannot be. It is literally life saving. But still, I'm
You should
asking.
know a standard CRTP pacemaker can come to anywhere between 5 to 6 lakhs, and a CRT with a defibrillator comes to as much as about 10 to 12 lakhs.
Okay, sir. But even then, it is literally life saving. It is ready all the time to save the person from the sudden death.
Yeah, the
So,
life
yes.
saving the right patient.
Yes, yes, yes. Professor Bang, all these things are there, but many a times, whenever there is a left main disease, there was a time when they all used to go to the surgery. But today, no more. Interventions are able to do that also. So, how do you manage the left main or the left main equivalent diseases, sir?
Correct. The left main coronary artery disease is the only disease where mortality is very high. 3 years
Yes,
mortality is 50%.
yes.
Even when lesion is 30 to 50%.
Oh,
So it's a very important lesion subset, which we have to look at differently. So these days, of course, PCI has greatly taken over because of advancing technology in calcium management and also the intravascular imaging and techniques. And the
okay.
stents also have improved remarkably,
Remarkably.
so providing good long-term result because thin struts, and then there are higher radial strength like Megatron, higher radial strength because left main requires higher radial strength because the muscle, the wall of the left main artery is as thick as the aortic because it's a continuity with the
Yes.
aorta. So
Iota. And
that's
especially
why.
if it is osteoarthritis, it is all the more difficult.
So basically, usually we can manage with the crossover, one single stent from left main to LAD. Usually, that is the simplest way. ABC is European Bifurcation Club, recommends that manage with a single stent unless it is very necessary to deploy two stent strategy. And that can be done only when it is a true bifurcation.
Okay.
111 or 101 or 00 or 011. So
Okay.
these three types are there. Then you can consider two stent strategy, provided
Okay.
there is a significant disease in the side branch and which is of about more than 70% and length of the lesion more than 10 millimeter. So based
Okay.
on imaging, usually we take decision because angiography is too limited to
Yes.
diagnose,
Yes.
particularly the circumflex ostium disease. And
Yes, sir.
FFR, of course, physiologic testing becomes very vital because to decide whether physiologically this block is significant or not. So
Yes,
there
sir.
are many patients now of left main disease who do not have multivessel disease. They can be managed with this. But if they have multivessel disease and diabetes, best for them is to go for bypass surgery.
Okay, sir. So I think that's a best way to manage. And now, Dr. Chaturvedi, what is the difference between hibernating heart and the stunned myocardium? Which one is more dangerous, and how do you distinguish and how do you manage?
Yes, so both are a type of a problem in the heart where for reasons which I will tell in detail, but a certain portion of the heart kind of goes into hibernation, like a bear goes in the winter for hibernation. So it
Okay.
reduces its metabolic expenditure and makes do with very less amount of nutritional requirement. And but then the bear also has to sleep. It cannot move around, and that's what it does in the winter. So the
Yes.
same thing goes for this. When an acute heart attack happens, then there is a large area at risk, which has the potential of becoming fully infarcted or dying because of the sudden occlusion, as Dr. Haigreve has pointed out. However, there is the central zone which finally dies, but the other zones start getting some supply from the other parts of the heart. And this area, which is in the penumbra zone, it is for some time it remains stunned. So basically, it means that this area is having less blood supply, and because of an acute insult, and because of that it has kind of decreased its output in terms of muscle contraction, and so that is the relevance that it contributes to the significant airway destruction after large MIs, typically anterior wall MI, and some of this part can recover, and with timely intervention with coronary interventions it does recover, and the usual time period for recovery is about 6 weeks or so.
Okay.
Hibernating myocardium is something like this, but on a very, very longer duration basis, where chronically, if there is large high-grade stenosis, multiple high-grade stenosis in multiple coronary arteries, they are not, there is no acute occlusion. There might be a chronic occlusion with some inadequate collateral,
Collaterals.
or there might be like 90-95% disease with no collaterals, but so the perfusion pressure and the perfusion is not is very inadequate in certain parts of the heart. So to conserve their energy, those parts start performing less of the work, which is muscle contraction, and so again they appear as if they are not contracting, and one might be thinking that this portion is dead. But through certain investigations, there are many, including PET, nuclear scan, and MRI. We can make out the difference between dead and viable tissue, which is hibernating.
Yes.
And
Yes.
suitable revascularization has been shown in some studies to increase the function from this part of the heart.
Okay. So, in which condition the this arrhythmias are more, in the stunned or in the hibernating?
They are very much more in the stunned part of acute
It's
attack.
an acute phase. Yeah.
Yes, yes.
Yeah.
The in the other hibernating, it is predominantly the scar and the area around the scar which is causing the arrhythmia.
Yes, scar also can cause. Yes. So, Dr. Rao, now what are the recent advances in the pacing? Because in olden days, we used to have a single ventricle and then two ventricle, and then we were keeping the pacemaker lead in the apex. Now you keep in the RVOT. So, what are the advances and what are the advantages and disadvantages of that? And now you have the leadless pacemaker also.
To give you a little bit background into your question so that we are on the same page. First of all, pacemakers are put for low heart rates. Now, normally what happens is the normal pacemaker of the heart generates electricity, and the heartbeat is generally 60 to 70 times a minute. When a person runs or exercises or emotional excesses, it can go up to 110 or 100, 110. Deep sleep, yoga, and other things, deep meditation, it can go down to 50. Now, what actually
Oh.
happens is when the heart rates become below that, below 50 on a waking person, and the patient becomes symptomatic like loss of consciousness, lightheadedness, these are addressed by instruments called pacemakers. Pacemakers are small devices which are the size of a matchbox. They are inserted on below the left clavicle, typically under the skin and the fascia, and it has a lead which goes into the right ventricle. And if there are two leads, it goes into right atrium and right ventricle. And what it does is, like a normal pacing, it paces. So this has been there. This is the background of your question. Now, coming to the advances, there are two important advances. The first thing I would like to say is where you're pacing. Now, what I would call, in a normal understanding of the people, I would like to call this as a precision pacing. Now, what we call in the technically as a conduction system pacing is a precision pacing. Basically, what we used to do was previously pacemaker lead used to be kept in the ventricle. It used to capture the myocardium and then result in the heartbeat. Now, what we do, there are very precise ways, technological hardware is available, wherein you place the lead, burrow it through the partition between the right ventricle and left ventricle, which is called as a septum, and you burrow it and capture the conduction wires of the heart, and so that you're precisely capturing the conduction system, not the muscle, not the septum. And this, what happens is, when you pace like this, the ECG, when you see, it looks like absolutely normal ECG.
Normal, yes.
This is relatively new. The idea and understanding is, it is just the understanding of the scientists and the technology is that in the future, such pacemakers will do better when compared to normal. But only time will tell. Now, the second advancement is, as evolution of the pacemakers went on for the last 20 or 30 years or more, the size became smaller and smaller. So, so the pocket is smaller. The patient
used to be so big earlier. Now it is so much.
No, you would be surprised. The first ever pacemaker, it was put on a trolley, and the person had to be wheeled in. So patient could not move out of the room. A big trolley and a big size pacemaker was there, and which was plugged onto an electrical thing like our laptops or electrical gadgets, and we started from there.
And incidentally, the first patient happened to be an engineer, and he went on asking questions to the person who was implanting, and he could not answer. He said, "I don't know. I'm just executing."
It's an interesting story, actually. His wife actually was a reason for his pacemaker. So I would always compare that to this Sati Savitri. I always say, give that. But she actually fought with the cardiac surgeons. They gave up, actually. They never thought anybody could. So because you raised, I'm saying, the story is that she actually was a graceful lady, and who tall, graceful lady as I described, and probably that was one of the reasons they couldn't refuse. So she went on and on, told great surgeons, and they and the engineers, and they created the first one in a shed, in a small automobile car shed, and they created this pacemaker. And anyway, and now coming from that size, we have come to a matchbox size, and over the period of time, the size became less and less. And now what we have in the last 5 years or so is what is called as a leadless pacemakers. These pacemakers are actually the size of a bullet. And the way it is they are used by hardware through the femoral vein in the groin, and these are placed by the cardiologists in the heart. And then that's it. And all the hardwares are removed. So the patient can get up and walk away within 6 hours. There'll be no scar. There'll be no area of infection. These are the advantages. Now, what are the disadvantages also we need to know? Now, a normal pacemaker, the cost would be something between 3 and 4 lakhs in any big corporate hospitals in the country. Now, if you implant a leadless pacemaker, it will go on up to probably 12 to 15 lakhs. So that is the thing. And the second disadvantage is that you can't do precision pacing with this leadless pacing. The precision pacing you do with a normal pacemaker. You can the lead.
You are seeing in the fluoroscopy and keeping it in the precise place.
It goes where it goes. You cannot tell I will do conduction system pacing through that. So that is a disadvantage. And also the cost is a disadvantage. The advantage clearly is that the infections are far less. There is no scar. There's a cosmetic advantage. So, and the last thing is the long term. We will have to see 10 years, 15 years from now. These pacemakers have lived the test of time. They have been here for 30 years or so. We'll see what happens after 20, 25 years. So these are the two major advantages.
When you say about the how long they last, there was the time whenever we used to put 30 years back, they used to last for 10 years. We had to put the other one and the lead used to be left. But now the things are much better. I think the lifespan of your pacemaker also has increased now.
Has increased. Another thing is these are like cell phones. Now, as you know, cell phones have more and more features than just talking. So the pacemakers also have coming with increasing algorithms. So, but computers are only as intelligent as the people who operate them. So you need to have a proper electrophysiologist who are going to program the pacemakers and make sure. Sometimes people buy most expensive pacemakers, but they don't use it because nobody knows how to program. So you need to all these things there. Thank you, ma'am.
Dr. Vivek, would you like to add anything to this? Because it's a very interesting topic and the people should know about it.
No, I think Dr. Highgrave has explained it so very nicely. Conduction system pacing and leadless pacing is the future of pacemaker.
Okay.
The cost is still a issue, but as we have seen repeatedly in India with many technologies, the cost does come down with time, and
Yes.
we will soon be having cheaper pacemakers to offer, and we'll have these two good choices depending on what is the clinical indication for what. Uh, but more importantly, I think while we talk of advances, we still see patients with heart block roaming around and falling down again and again, and it is unrecognized, and anti-epileptic medications are started to these patients.
Oh my God.
So it is very, very important to increase awareness
Yes.
amongst
Yes. Yes.
not only the public but also in the healthcare
Among the
providers.
doctors also. Yes.
Yes, absolutely.
Very, very, yeah, very nice. Dr. Bang, what is the current status of secondary prevention in coronary artery disease? We always talk about the primary angioplasty, but what about the secondary prevention?
Very good question. There are twofold problems. If you don't manage or don't follow up or don't adhere to the treatment, compliance is not good. Then there are two problems. If the antiplatelets are stopped, then thrombotic lesions will develop in the stent. Or if the LDL level goes up because you stop the statins, then ISR will come up as instant restenosis. So these two challenges are there, but there is definite advancement in antiplatelet therapy. It has become so wonderful that we hardly see acute stent thrombosis with current antiplatelet regimen. Plus, there is very good treatment for LDL management and
Yes,
overall, or except LPA, everything
yeah,
else can be very well managed. But
yes,
in sooner, no sooner, LPA will also be managed very well. Drugs are in phase four, almost phase four trial, where pelacarsen and olpasiran will be for LPA. So once all these drugs come in vogue in practice, as very well Vivek said, that the cost comes down with the time as the use goes on for everything. The new drug is expensive, but cost comes down over a period of time. New device is also expensive, but cost comes down over a
yeah,
period of time. So these two challenges are there, but hats off to the researchers. They have come out with excellent secondary prevention drugs. But what we talk is correct, but then we don't talk of non-HDL cholesterol. We talk of LDL all the time, but non-HDL cholesterol also equally important. To
yes,
maintain good result, LDL has to be below 50 or maybe less than that, and non-HDL cholesterol has to be less than 80.
yes,
So unless you have both these managed very well with the current line of statin therapy and all other drugs using ezetimibe and all other drugs are there available, where resistant patient or maybe familial hypercholesterolemia is another subset which is very challenging
yeah,
subset.
yeah, the
And,
family also.
common, and it's not uncommon. It's 1 in 200, so it's not uncommon, and
Yes,
that
sir.
requires specific treatment, requires intravenous drug to manage. Otherwise, ISR is very high in those patients. So
Yes,
management and adherence to the drug becomes the key for the management.
yes,
Nowadays, antiplatelet therapy is ultra short. So 1 month dual platelet or 3 months dual antiplatelets or maximum 6 months or 1 year maximum. And
okay,
then after that there is single antiplatelet agent. So nowadays, of course, advances in therapy, the drugs, the understanding about the drug, the research has helped quite a lot managing stents afterwards, reducing the stent thrombosis and ISR both.
yeah, whatever the advancement, but still they don't have the drug to increase the HDL cholesterol. For
Yeah, well, no,
increasing the HDL cholesterol, they have to
no,
exercise and stop smoking. So again, we
yeah.
come back to the
No,
lifestyle.
HDL also increases little bit, but it doesn't increase major. It
No, it
increases
doesn't.
little.
Yes,
But mind you about the HDL, that if it crosses 60 or 60, then it
yes,
becomes
sir.
like LDL. So it produces the same problem like LDL produces. It produces
Yes,
new disease. So it has to be below 60. Even if it is Above 60 means it has to be reduced by giving proper drugs.
Okay. Dr. Vivek, in spite of best treatment and anything, sometimes they go for the heart failure. And do they have any good drugs for controlling what they call as the fantastic four? How do they act? And how can you prevent the patient from going for the stage of transplant?
Yes, ma'am. So this is why appropriately, if we were to go back to the very beginning, then the same risk factors which are there for CAD, diabetes, hypertension, smoking, and some other lifestyle factors like obesity and alcohol. These are
Hmm.
the ones which are also propelling the heart failure epidemic in India.
Yes, sir.
Now, so you obviously have to control these. The things which are most important once the diagnosis of severe heart failure with systolic dysfunction is established is to initiate as early as possible in small doses the fantastic four, the pillars of the GDMT or the guideline directed medical therapy.
Okay.
Amongst these are the renin-angiotensin modulators, which are
Okay.
things like ACE inhibitors, angiotensin receptor blockers, or what we call as angiotensin neprilysin ARNIs, which are the
Arni. Yes,
sacubitril
Arni.
valsartan. Yes,
Yes.
sacubitril valsartan, which is uh, so these are the ones which are the RAS inhibitors. Then we have the very well known beta blockers,
Yes.
and of these, the three big ones with known effect on heart failure have been carvedilol, metoprolol, and bisoprolol. So these are the ones which are used. And then we have the so-called MRAs, or the mineralocorticoid receptor
Yes.
antagonists.
Receptors.
So spironolactone and eplerenone are the ones which is used. The recent drug which has come into this and it has taken the world by storm is the SGLT inhibitors. So that is sodium glucose cotransport 2 inhibitors. And in India, the common ones available are dapagliflozin and empagliflozin. And they have also been known to dramatically affect the heart failure hospitalization and to some extent other parameters in patients with heart failure. To
Oh.
this, I must add one more pillar, which is very important, and people often don't pay attention to it, but it is nearly as powerful as this, and that is a suitable exercise regimen.
Yes.
So, graded increase in physical activity and exercise is known to reduce heart failure mortality and morbidity. And
Oh.
besides lifestyle, also we are also putting much more attention on things like preventing infections like influenza by vaccinations to these people. It prevents hospitalizations, and then device therapy in terms of cardiac revascularization, resynchronization therapy and ICDs also go a long way in preventing these patients from reaching the stage of end-stage heart disease requiring transplantation.
Dr. Vivek, what about the tachyarrhythmia-induced heart failure? How do you manage
Yes.
them? That is very important. You are an
So,
expert, so I would like to learn.
so So very important, ma'am. And tachyarrhymia-induced cardiomyopathy or TIC is the unequivocal this thing for some kind of aggressive treatment for these people. In adults, the two commonest ones are atrial flutter and atrial fibrillation. They often coexist with heart failure. They worsen the heart failure, and many a times it has been shown in recent studies that their aggressive treatment by ablation has prevented heart failure patient
Yes.
transplant list patients. They've been delisted from the transplant list for this.
Yeah, yeah.
People who do not have access to ablation or who would want to wait, cardioversion is a cheaper though transient modality for treating these TICs.
Excellent, excellent. I think the most of the pediatricians should be aware of it, and just go on treating as heart failure is not. They have to treat. So they may think that the tachycardia is because of the heart failure, but on the contrary, the
Yes.
tachycardia may be the cause for the heart failure. So
So
we
one
have
very
to think of it.
important phenotype to remember for what you're saying for pediatricians is children with heart dysfunction who have a very rapid heart rate, which looks like sinus, but actually it is atrial tachycardia.
Yes,
So that's a
yes,
phenotype people should remember, because if it is there, then ablation of this atrial tachycardia will lead to prompt resolution in an improvement in heart function.
yeah.
If I may
Uh,
add, this is more
yeah,
than the
please,
rate,
please.
it is the incessant tachycardias. So the incessant means whether you give drugs or you give shock, the tachycardia never goes away. And they are very slow, the
Yes,
120, 130. These are generally
yes,
lead to heart failure. As Dr. Vivek has rightly said, they should be taken up for radiofrequency ablation, and that's curative.
yeah. Yeah. Points are well taken. Thank you. Very nice. Dr. Rao, what are the causes of sudden death? Because, nowadays the sudden deaths are increasing. And what are the major causes, and how do you tackle and how do you prevent it?
Yes, sudden deaths are a very important problem in our country. 10% of all the mortality, all deaths are sudden, and this we established about more than 10 years back in our study. Now there are three important causes of sudden death that are clinically relevant. There are many, but three important. One thing is a sudden death occurring after a heart attack. Second is patients with heart attack in the past, very long,
Okay.
and third is
Yeah.
patients with a weak heart. Now the first
Okay.
thing is, now, patients who have heart attack have chest pain and they reach hospital for a primary angioplasty or lysis. But then it should be remembered that a significant number of patients who have heart attack never reach the hospital. They are not
Yes.
known to the registries.
Yes.
They
Yes.
just have heart attack, have a cardiac arrest, and die instantaneously, or while bringing to the hospital, or in the hospital before anything can be done. At all these three stages, these people can die. So I would say that among all the preventable cardiac deaths and arrests, this is the most important thing in our country. So the
Yes.
way to do it is aggressive screening for coronary risk factors, number one, and number two, timely treatment of heart attacks. Extremely important. Now, the STEMI program has come in India. It's going in a big way, and I hope it goes much bigger way and it reaches every nook and corner of this country. This STEMI program is important because heart attacks are important if they are treated only in the first few hours, the golden hour, 1 hour,
Yes.
2 hours, 3 hours.
1 hour.
But
1 hour.
after that, it is it leads to irreversible heart failure. So the STEMI program should go in a big way. Heart attacks should be diagnosed, recognized early, transferred to the right places, and quickly reperfused and revascularized. So this is a proper prevention of heart attacks by modification of coronary risk factors. Proper treatment, timely treatment of heart attacks is the most important prevention for sudden death. The second part is when patients who have heart attack in the past, say 5 years, 10 years, or past heart attacks, and they have some weakness of the heart because of the heart attack, and as shown by echocardiogram. Now, what happens is these people develop scars and circuits around the scars.
Yes. The
They can
fibrosis
have,
of the arrhythmias.
these people can suddenly present with a loss of consciousness or a lightheadedness or a palpitations, and suddenly these are the or they can suddenly have a cardiac arrest and drop dead. So
Yes.
anybody with a weak heart and with a heart attack in the past, especially with ejection fraction as shown by the echocardiogram of 35% or so, these must be evaluated by the electrophysiologists for the prevention and identification of the
Absolutely.
right candidate for sudden death. So once you
Absolutely.
identify, these people can be given implantable cardioverter defibrillator ICDs in the right candidates,
Yes.
and
Yes.
so that when a cardiac arrest occurs, it shocks and prevents death.
Yeah.
And the last cause of heart attacks is the weak heart. No, heart attack is the commonest cause of weak heart, but that's not the only cause. Anybody with the echocardiogram showing ejection fraction of 35% or less, normal ejection fraction is 50% or 55% or more, 35% or less are at a risk of cardiac arrest and sudden death. These people should be evaluated, monitored, and screened. For the right people should be given defibrillators and to prevent it. So all these three are important at different stages of their pathophysiology.
What about the long QT syndrome and the hypertrophic obstructive cardiomyopathy? They all also will have the sudden death. How do you
Yes.
manage them?
I
Those are
did say that. Pardon,
young
sir?
sudden,
One, sir?
young sudden deaths.
Yes, sir. So, as I rightly said, heart attack is the commonest cause of sudden death, but that's not the only one. No,
Yes.
young athletes who fall dead
Yes.
suddenly, one of the
The
reasons is they
footballers,
have
they die on the ground.
possible. And people who die under 40 years of age, and children are in the families who are dying under 40 years of age. These people, no doubt, in India, heart attacks can occur even in less than 40, but nevertheless, these things should be kept in mind. Now, the easiest way to diagnose them is by an ECG. So anybody
Yes.
who has one person dying, everybody, now the families are distributed all over the world, extended families.
Yeah.
So one should,
Yes.
so in my practice, I make sure that all over the world they are contacted and at least an ECG is done and an echo is done and shown to the nearest cardiologist to see if they are also a part of this syndrome. Because once it is
Okay.
there, we can monitor them, we can screen them, and we can offer them drugs, or even very rarely, children we don't do often. Very rarely, if they are also at a very high risk, we can offer them a defibrillators. And hypertrophic cardiomyopathy, there's so many drugs are coming up, and these people also should be screened for high risk of sudden death, and they should be offered defibrillators.
Okay, sir. Thank you very much. Dr. Professor Vijay, what about the role of LPA as a risk factor for coronary artery disease? And what about the newer risk factors like air pollution and the noise pollution? How do they affect, and how are they increasing the incidence of heart attack?
Correct. And epicardial fact,
Yes, epicardial fact. Yes.
you forgot. So that is your question. You raised
Yeah.
that question.
Yes, yes.
Okay.
Because we talk about the obesity, truncal obesity, fatty liver, everything.
So
But
let
being
me elaborate
cardiologists, we must give importance to the epicardial fat also.
as well. Correct. So let's cover one by one LPA. LPA is a genetic risk factor, but now it is defined as independent risk factor, irrespective of whether LDL is high or statins are required. And these drugs don't can be treated by statin. At the moment, there is no drug available to treat high LPA. And in India, the incidence of high LPA is 25%. Means of the population that we have, 100 people, if we take, 25 will have high LPA. That's a very high incidence in India, which leads to early calcification and early blockages in the coronary artery. In aortic stenosis also is known to occur in high LPA. So
Yes,
LPA is a cause of premature coronary artery disease that we
yes.
see in India. The premature coronary artery disease occur less than 10 years. Younger people will develop heart disease in India.
Yeah,
Means
the
55.
youngest child I have done angiogram is 9 years old. He had
Yeah,
a triple vessel disease, but he had a familial hypercholesteremia.
yeah,
So
yes.
that also
Familial
has to be kept in mind. Yes,
hypercholesterolemia is another cause that
yes, yes,
we have. So LPA is definitely a very big risk factor. No treatment available, so it's not modifiable risk factor at the moment. So that remains a big challenge, and incidence
yes,
in India is very high.
yes, sir.
Second, you said epicardial fat. Now, epicardial fat is least spoken amongst all the risk factors because nobody is aware of the epicardial fat. Epicardial fat is an atom which is to be defined very well, and the researchers don't have consensus on what to call epicardial fat. Those which are intrapericardial,
Hmm.
eh,
Yes,
some people say those are epicardial fat. Some people say extrapericardial
yes,
also is a epicardial fat. Now, both these atoms together becomes epicardial fat for third group. So there is lack of consensus. This is the main reason that it is not spoken authentically in any of the forum, scientific forum. But
yeah,
it is definitely there, and it is defined as what is normal, because normally also it should be present. It act as an endocrine to manage the blood vessels very well, and even provides nutrition to the blood vessels. The
yes,
epicardial fat that you see around the coronary arteries, that those are very helpful in providing nutrition and also the endocrine function. So those are very, very important. But if they
yes,
are in excess, so let's first define what is normal.
yes,
Normal epicardial fat is up to 5 millimeter,
yes.
measured either on the echo or CT scan or
Yes.
MRI. MRI is the best
Okay.
because resolution of the MRI is much higher
Much
than
better.
echo and the CT scan. Then if you define it in volume, then 125 up to 125 ml is normal. More
Okay.
than 25 ml epicardial fat is abnormal. Then it
Okay.
associates very well with the coronary artery disease. It is
only
a
cognitive.
observational study which is done that if you have a increased
More
coronary artery
question.
disease, epicardial fat is found high in these some of this group of patients, and those are detected by MRI.
Yeah. So
And
recently I heard
third,
Dr.
you said
Naveen C. Nanda.
one. Third, you
Yeah.
said LPA, epicardial fat, and I forgot the third one. What you
The
said?
noise pollution. Noise pollution.
Very important. Very,
So
very
before
important.
we go to the noise pollution, I would
Very
like to
important.
tell, sir,
Very important.
Dr. Naveen C. Nanda, he gave a very elegant and excellent lecture on epicardial fat, how
Yeah,
it
I know.
increases the heart attack. He spoke
Correct.
so well, very
Yeah,
impressive. I think
very
it
impressive.
was an eye opener. Okay, please go
Yeah,
ahead, sir.
correct. So now let me speak about the air pollution. Now, air pollution is again another risk factor which is least spoken. People are not aware of it. Even
Yes,
cardiologists are not aware of it. Now, there are two types of air pollution. One is environmental, which is outside your
yes.
house, and another one is residential.
Okay,
Now, there is a study done in America which says that a global study which says that almost 2 million people in America die in China, America, and India. Out of that, the highest number of people dying because of the air pollution are in India.
yes, yes.
But
Especially
particularly
particle 2.5 and particle 10, they are the major particles.
the smaller particle, they can cross the blood,
Cause
the
the
bronchial
inflammation. Yeah.
caliber and cross into the system and produce circulatory effects of those air pollution. So it has to be a nano particle which can cross, which can
Yes.
produce major. Otherwise, it will produce upper respiratory tract problem or maybe maximum smaller lung problems, but not
Okay.
coronary artery disease. Now, sudden death is defined very high because of the ozone pollution.
Yes.
In it's a major cause of sudden cardiac arrest. It can produce hypertension, it can produce MI, it can produce sudden cardiac arrest. It increases adrenaline, noradrenaline, and all other hormones which are counterproductive to good health.
Okay. Okay.
So air pollution is a very, very important
Big
problem. A
problem. Yes.
big problem and in the house we can control air pollution. Outside we have no control. In the house, how we can control? Use chimney while you are cooking, because
Exhaust
those
fan.
chimney above
Okay.
the
Okay.
gas.
Yeah.
Chimney
Gas.
works out very well for reducing air pollution. Second is
Okay.
air condition is the
Yes.
major cause of air pollution. Even when
Okay.
we have filter, so many filters are there, but even with the filter, air pollution is very high with the air condition. But without air condition, we cannot manage these days. The global warming has reached to that level that it is very difficult to live without the air condition. Now,
Yes.
so much rain is there, overall temperature has come down, but we require
Yeah.
air conditioning. Without that, we cannot see it. That's the situation that we are facing.
So what
So,
about the noise pollution?
noise pollution also, there is a description that if you have a sound which is above a particular range,
High decibel.
high,
70, 90, above that. Okay.
above that, then it produces definitely some stress in the life, and again increase in adrenaline, noradrenaline,
Yeah.
and that leads to CAD and hypertension.
Dr. Vivek, the people dancing for the DJs and high decibel, they have sudden arrhythmias and they collapse there. What could be the reason?
Ma'am, part of these are actually the unidentified channelopathies which are there,
Correct.
Okay.
which are triggered by exertion or by excessive
Sound, by
stimuli.
triggered by sound.
And they would have
Yes,
taken
yes,
alcohol, vasodilatation,
yes.
and on top of that, yeah, all together.
So a lot of drug intake and drugs are also, I think most of them are still unidentified in the Indian context.
Okay.
So a lot of it is going on. I think it is mostly, it is not a single thing, but it is a multi-hit kind of a thing where you have a genetic tendency and some kind of an extraneous factor, either too
Yeah.
much adrenaline or any kind of a substance abuse kind of
Granulopathy.
thing. Yes, correct.
When you said, I remembered in the intrauterine life itself, this process can start. So, how do you detect, and what advice do you give to the women, especially to prevent their future children becoming cardiac patients?
Yes. So, in the context of first of all the cardiometabolic thing, very long time back, and a lot of good studies have been done by pediatricians in India. Read this. There's something called the Barker's hypothesis,
Yes.
which is of intrauterine growth retardation, which is subsequently increase in weight after the birth leads to hyper insulin states with more and more metabolic problems happening like hypertension, dyslipidemia, and dysglycemia in later life. So IUGR is a very important component of this as far as India is concerned. So I think number one thing which we must address for young expecting mothers is that IUGR should be addressed, and because it is paradoxically will cause problems related to obesity later.
Correct.
So that is very important. Supplementation with the known things which are known to prevent defects later are also very important. And like you have already mentioned that smoking and alcohol is on the rise in the young Indian women, and again. Not only is it causing problems to them, but by raising their blood pressure, and it is also compromising the future generations. So timely
Absolutely.
detection of hyperglycemia, hypertension, and avoidance of substance abuse, good nutrition, avoidance of IUGR. These are the main things which will help in having a healthy generation ahead.
Yeah. Yeah.
Madam,
More
Madam, I may
Yes,
suggest.
one more
please
thing.
answer.
One more thing I just want to add: intra-amniotic fluid examination can detect several cardiac conditions
Anomalies.
which are fetal,
Yes.
and then you can plan accordingly the treatment.
Yeah,
Yeah.
so the
Intrafetal
triple rule
treatment
out test
interventions
is
are also done.
mostly used for that.
Intrafetal interventions are also
Yes.
nowadays
Yes.
is the way
Dr.
of.
Rao.
Madam, there is a messages repeatedly from organizers that we have to conclude. The audience have
Yes.
all completely left, so I think we should
Okay,
conclude.
okay,
Please
okay.
conclude.
In that, if we want to conclude, each one of you, how do you want to, what advice do you give to the doctors? Dr.
We are talking of cardiologists, correct?
Yes, sir.
MI, heart attacks. She talks about heart attacks. Prevention of
No,
heart
we are
attacks.
talking of cardiologists at the moment, or what particularly advice in terms of what? To the
Anyone,
cardiologist
sir, in general.
in general.
What
So
are
to
the
Health to healthcare providers. To healthcare
to
healthcare?
providers.
Yeah.
healthcare provider. Now, coronary artery disease is particularly on increase due to increase in diabetes, obesity, hypertension, smoking, and all the risk factors which are there. In India, LPA is one of the very important risk factor. 25% of population have high LPA.
Okay.
So all these risk factors must be studied. After the age of 30, everyone should go for a cardiac checkup, including lipid profile, to detect whether they have a familial hyperlipidemia or not.
Okay, sir.
So LPA can be done at any age. There is no age bar for LPA. Once it is detected high, it remains high
Okay.
irrespective of at what age you are. So if
Dr.
it is
Vivek?
uh,
My single piece of advice is ki very strongly promote lifestyle and walk the talk.
Yes. Dr. Rao?
Very clear. Diabetes is the biggest killer of contributor to heart attacks and the biggest killer in our country. So please screen, and it is silent, no symptoms.
Yes.
Please screen for diabetes, do HbA1c, not just sugars, and maintain diabetes properly. That's the biggest advice I would like to give.
full checkup, full checkup.
Yeah, that's why somebody had written, no, instead of bothering about HB1 visa, bother about your HbA1c, that is more important. And jokes apart, jokes apart, the obesity and is the mother of 5 deadly diseases: diabetes, high blood pressure, high cholesterol, heart attack, and Alzheimer's disease. So I think the younger generation should keep trim and slim, and that's the way to be healthy, wealthy, and
Diet,
wise.
good diet and
And
exercise. Good diet
yes,
and
Thank you.
regular exercise and yoga,
and,
meditation are the tips. And
and
thank
diet.
you very
Diet.
much. I had a wonderful time, and I learned a lot from all of you. Thank you so much. Wish you all a happy
Thank you,
Navratri.
madam.
Thank you,
Good night.
everyone. Thank you.
Thank you for this
Thanks. Good night.
opportunity. Thank you.
Thank you. Thanks.